Hey guys, sorry for the mishap and the confusion. We're back on the main channel and the main video from where we will be streaming our discussion on multiple sclerosis. I'm Dr. Patil and welcome you all to this stream. Those who had connected with the earlier stream, we will be continuing our discussion in the part 2 of multiple sclerosis tomorrow. For today, we will begin with the part 1. So what are we covering in part 1? In part 1, primarily we'll be focusing on understanding the concepts behind multiple sclerosis. What is it as a disease? What causes it, what are its clinical features, and how do we classify multiple sclerosis into different types. In part 2, we will learn about the diagnosis and management. But first, let's begin with the basics. What is multiple sclerosis? The simplest answer anybody can give me when someone asks what is multiple sclerosis, a dangerous world medical lecture. Sir, this is a demyelinating disorder affecting central nervous system. What does that mean? It is a disorder where myelin sheath, which is present around the neurons, is getting damaged. And the disease is predominantly affecting the CNS, not the peripheral nervous system. Right? Now, why myelin sheath is important for us? Because the myelin sheath helps us to conduct the impulse faster. Now, normally, like when I have to move some body part or some muscle, I have to generate a signal, which is an electrical impulse in the cortex of the brain, right? The specific area will be called as motor cortex because it is concerned with motor functions. That electrical signal will travel through the axons of the motor neurons to reach my neuromuscular junction, and then I will be able to contract my muscles. At what rate this signal will travel depends on presence or absence of myelin. So if I have myelin, then the electrical signal will jump from what we call as node of Ranvier. From one node of the Ranvier to the next node of Ranvier, the electrical impulse will keep jumping and it makes the conduction faster. But if I do not have the myelin sheath, then the electrical impulse has to travel throughout the axon by causing its depolarization. So obviously this will take longer time. Signal will reach from the cell body to the axon terminal with a longer duration in comparison to the neuron where myelin is present. If myelin is present, the signal will jump faster from one college to one node of Ranvier to the next node of Ranvier. This kind of conduction we call it as saltatory conduction. So disorders which strip this myelin from the neuron will be called as demyelinating disorders. And this multiple sclerosis is a demyelinating disorder affecting the central nervous system. Can you give me an example of the demyelinating disorder affecting the peripheral nervous system? Like let us name some demyelinating disorders and then we will talk about multiple sclerosis. So demyelinating disorders can be classified as the ones that are affecting the central nervous system and ones that are affecting the peripheral nervous system. The ones that are affecting the peripheral nervous system, the classical example, all of you are pretty much familiar with them, that is GB syndrome. GB syndrome. Transverse myelitis, yes, it is also a form of demyelination, but when you say transverse myelitis, what structure we are referring to? We are referring to spinal cord. And remember, brain and spinal cord are part of central nervous system. I asked you the examples for the PNS demyelination. Yes, the GB syndrome is a classical example for demyelination of the peripheral nervous system. And then there is also one more disorder which is more chronic. The GB syndrome is an acute form of demyelination. There is also a chronic form of demyelination called as chronic inflammatory demyelinating polyneuropathy or CIDP. Chronic inflammatory demyelinating polyneuropathy and GB syndrome. These are classical examples. Now, when it comes to the disorders affecting the central nervous system where demyelination can happen, the first classical example that all of us should quote is, in fact, multiple sclerosis itself, and that is what we are going to discuss today. Apart from multiple sclerosis, we have another disorder which is called as transverse myelitis. We will discuss as part of multiple sclerosis itself, but there are other causes. Apart from multiple sclerosis, you have something called as neuromyelitis optica. Neuromyelitis optica. Then you have something called as anti-MOG disorder. Anti-MOG disorder. These are all demyelinating disorders of the central nervous system. We will write one more. I will give you the clues. You should tell me which disease I'm talking about. This is a complication of faster or rapid correction of hyponatremia. Whenever we have hyponatremia, we generally give 3% saline to increase the sodium levels. But if I overshoot or I do this correction much faster than anticipated, I can cause demyelination of the pons particularly and other areas of the brain. So what this disorder is called as? When demyelination happens because of the rapid correction of hyponatremia. What is the disorder known as? It's called as osmotic demyelination syndrome. Osmotic demyelination syndrome. It's also called as central pontine myelinosis. It's also called as central pontine myelinosis, where because of rapid correction of hyponatremia, we end up causing demyelination of some part of the brain, mainly the pons. So these are all demyelinating disorders of the central nervous system. So in all these conditions, what is the underlying problem? For some reason, the myelin sheath is getting damaged, making the conduction of electrical impulses through the neurons much slower, almost close to nil, right? Okay, so that is the basic understanding that we need to have. With that basic background, let us talk about the multiple sclerosis. Multiple sclerosis. What is multiple sclerosis? Number one, we have already learned that multiple sclerosis is a demyelinating disorder of central nervous system. Demyelinating disorder of central nervous system. Okay, clear, understood. Second thing, what causes it? Is it an infective disorder? Is it a traumatic disorder? Is it because of some road traffic accident? Or is it because of some particular virus infection? Or is it because of an autoimmune pathology? What is it? What kind of disorder it is? Remember, multiple sclerosis is an autoimmune disorder. This is a autoimmune disorder. It's an autoimmune disorder. So basically, your own body is producing antibodies which are targeting the myelin. Obviously, they will ask you which antibodies and all. I will come to that point. It's a demyelinating disorder of the central nervous system. The neurons of the CNS are losing their myelin because your own immune system is targeting them. Your own immune system is targeting them. Okay. The third point that I'm going to mention here is this is a polyphasic disorder. Now, what do I mean by that? See, for example, GB syndrome. How often GB syndrome recurs? Like if I get GB syndrome, what is the chance that I will get one more episode of GB syndrome in the future? Remember, GB syndrome, the recurrence rate of GB syndrome is less than 5%. That's why GB syndrome is often described as monophasic illness. What do I mean by that? For most patients, GB syndrome is once in a lifetime event. They will get GB syndrome once, and unlikely that they will have one more episode of demyelination, one more episode of GB syndrome. Less than 5% of patients may experience one more episode. On the other hand, multiple sclerosis is a polyphasic disorder. What does that mean? These patients will have multiple episodes of demyelination, not a single episode. So it is a chronic disorder where repeatedly, again and again, demyelination keeps happening. Classical comparative example I can quote is, some of you might have studied about a disease called as alopecia areata, where patients have this coin-like loss of hair, right? They will have patches of hair loss. And in such patients, what happens? You give them some steroids, because that is also an autoimmune disorder, some topical steroids, some minoxidil. That patch where the hair loss was there, the hair will come. Maybe after a few months, few years, another patch somewhere else, they will start losing the hair. So it keeps recurring again and again. Multiple sclerosis is also like that. It keeps recurring again and again. In fact, the term multiple, kyun aaya hai? We are using the term multiple because the episodes of demyelination happen multiple times. They happen multiple times. So this demyelination occurs. It is recurrent, and every time it did not affect the same structure. Like for example, cerebellum, right? Let us say on day one, there was demyelination of the cerebellum. Next time when demyelination happened, it need not only target cerebellum. It may be affecting this time the spinal cord, the other time the subcortex. So it is affecting different anatomical structures every time. It is not affecting the same site every time. Same like alopecia areata. Sometimes I am having a hair loss patch here. Once I recover it here, somewhere else there may be hair loss. So it is not affecting the same site again and again, right? So it is a recurrent demyelination affecting different anatomical structures, affecting different anatomical structures. So it is not affecting the same anatomical structures every time. And because of that, the symptoms are also going to be varying every time the patient develops a demyelination. Like every time they're not going to come with same symptoms. Symptoms are going to depend on which structure is affected by the demyelination, right? So now we know why is it called as polyphasic disorder. The only pending thing to address is if it is an autoimmune disorder, whether it is a cell-mediated immune disorder or is it a antibody-mediated immune disorder. Please remember it is both. There is cell-mediated plus humoral immunity involved. Cell-mediated plus humoral immunity. That means the cells are also causing damage as well as antibodies. And if antibodies are involved, then they will ask you a question, which antibodies are involved here? There are two antibodies that we need to remember here. The antibodies involved in multiple sclerosis. The first one is called as anti-myelin basic protein antibody. Anti-myelin basic protein. So in the myelin sheath, to anchor the myelin sheath to the axons, we need a protein called as myelin basic protein. They start producing antibodies against this. That is why myelin will not be able to stick to the neurons or the axons. And this is the most common antibody that we see in patients with multiple sclerosis. Another antibody that we can see is anti-myelin oligodendrocyte glycoprotein antibody or anti-MOG antibody, right? These are the two common antibodies that we see. If they ask you on MCQ, what is the most common antibody? Most common antibody is anti-myelin basic protein antibody. So these antibodies and your T lymphocytes, both of them are causing the damage to myelin sheath. That is why we end up losing myelin. Okay. Now, coming to the epidemiology of this disease. Once upon a time, multiple sclerosis was a very, very rare disease in India. When I was an undergraduate student, we would barely discuss about it. Like once in a while, fleetingly, our teachers used to talk about multiple sclerosis. It was not a common part of our ward rounds or discussion because it was rare. But with passage of time, the prevalence is increasing. Okay. Now, I've already told you that this is an autoimmune disorder. So can you guess which gender is most likely to be affected? Generally, we say that autoimmune disorders are more common in females than males. Like for example, Ancillary rheumatoid arthritis, Hashimoto's thyroiditis, Graves' disease. We talk about an autoimmune disorder, it is most likely more common in females than males. But here is an exception. Here is an exception. Multiple sclerosis is more common in males than females with a ratio of 2:1. So there are only few exceptions for this rule, right? Otherwise, autoimmune diseases are more common in females. And what is the mean age of onset? With respect to age of onset, this is not an exception. Majority of autoimmune disorders, the age of onset is middle age. Like you talk about SLE, what do you say? Reproductive age or middle age. Talk about rheumatoid arthritis, Hashimoto's thyroiditis, Graves' disease. All of them are typically more common in the middle age. Even multiple sclerosis, the age of onset is usually middle age. So 28 years to 31 years of age is the mean age of onset. That is where the first episode of demyelination happens. Remember, multiple sclerosis is a disease जहाँ पे demyelination बार-बार होता है. Again and again they will go through demyelination. Majority of patients somewhere between their 28 to 30 years of age, roughly their first episode of demyelination happens. And here's an interesting point. Geography plays a very, very important role in your risk of developing multiple sclerosis. The countries which are far away from the equator have the higher prevalence of the multiple sclerosis compared to countries which are on or closer to equator. Now, India being closer to equator, we have lower prevalence comparison to the countries which are closer to equator. So there is higher prevalence of multiple sclerosis in countries closer to equator. Can you guess what could be the reason? Not closer, far away from the equator, right? In other words, I can say closer to poles. What could be the reason? So if you take a globe and start moving away from the equator, as you start moving away from the equator towards the pole, the prevalence of the multiple sclerosis goes on increasing. What could be the cause? Well, when we have studied the risk factors, and I remember I made a statement saying that the prevalence of multiple sclerosis in India is increasing. What could be the cause? So when we study the risk factors, we find out that genetics does play an important role, but environmental factors also play an important role. And the most important environmental factor that is well proven to increase the risk is vitamin D deficiency. So countries away from the equator have probably lesser sun exposure, and that vitamin D deficiency may contribute towards their risk of developing multiple sclerosis. In India, we're relatively safe, but in the modern generation, all of us literally take a bath in sunscreen, and sun exposure is coming down. Most of us are working indoors. We have very limited sun exposure. जब भी बाहर जाते हैं तो sunscreen थोप के ही जाते हैं. So the prevalence is increasing, right? That explains why we have started seeing multiple sclerosis cases of late in last one and a half decade. Okay. So now coming to the risk factors for multiple sclerosis, genetics plays an important role, especially those who have this HLA-DR B11501 variant. They are associated with increased risk. Certain HLA variants are also protective, not important for the exam. Coming to what are the environmental factors that can increase the risk of one developing the multiple sclerosis, vitamin D deficiency, then Epstein-Barr virus infection, especially in childhood. For some reason, if you develop Epstein-Barr virus infection in adulthood, it does not increase your risk of developing multiple sclerosis so much. Rather, if you develop a Epstein-Barr virus infection in childhood, the risk of developing multiple sclerosis significantly increases. And this is one peculiar virus. You talk about pathogenesis of SLE and various other autoimmune disorders. Epstein-Barr virus comes into picture. So vitamin D deficiency and Epstein-Barr virus infection are two important environmental risk factors. Okay. What else can be a risk factor? Even obesity is considered to be a risk factor for, especially the adolescent. Obesity is a risk factor for someone developing multiple sclerosis. So these are environmental factors. Genetics wise, the HLA-DR B11501. Okay. Now let us see what clinical features we can expect in a patient who has developed multiple sclerosis. To summarize, what is multiple sclerosis? It is a demyelinating disorder of the central nervous system. Why are we calling it as multiple sclerosis? Because it is a polyphasic illness. Repeatedly, again and again, right? Multiple episodes of demyelination affect the patient. That is why it is called as multiple sclerosis. And it need not be the same anatomical structure which will go through demyelination again and again. Every time it's a new site, right? You can compare this disease to the modern day guys, right? They are dating a new girl every time. It's kind of, right? Every time it is targeting a new structure in the brain. Now, why demyelination is happening? Because it is an autoimmune disorder where T cells as well as the antibodies are causing the damage to the myelin sheath. What is the main or most important antibody? The most important antibody is anti-myelin basic protein antibody or anti-MBP antibody. Okay, so when we cause the demyelination, what symptoms we are expecting? We already know that myelin sheath is required for faster conduction. Once they strip the neuron of its myelin, the conduction velocity becomes significantly slower, so it will not be able to function properly. Okay. Now, please let us read the statement that I have already written here. MS is characterized by repeated attacks of demyelination affecting different anatomical structures. There are no specific clinical features. Why? Because if you're targeting different anatomical structures, every time you target a new structure, you will have new symptoms. So there's nothing specific I can say. Then when do I suspect multiple sclerosis? Yes, there are some clues which will help us to suspect multiple sclerosis in an MCQ based question as well as in a clinical patient. For understanding when to suspect multiple sclerosis, we should know what are the common sites of demyelination. The most common site of demyelination that gets affected in multiple sclerosis is the spinal cord. Spinal cord. Now, can anybody tell me what structure is most likely to get affected in spinal cord? So when we see the spinal cord, right, if I take a cut section of the spinal cord, this is it. This is what it is going to look like, kind of, right? In the center, we have the gray matter. And in the periphery, we have the tracts which are either coming down from the brain or they are going up to the brain, right? Ascending tracts and descending tracts, and we have the central gray matter. Which structure is most likely to be affected by demyelination? Just think about it. In the nervous system, the central nervous system, you have gray matter and white matter. right? Now, what makes the gray matter gray and what makes the white matter white? The white matter appears white because of the presence of myelin, right? And in the places where myelinated neurons are minimal or non-existent, that part of the brain is going to look like gray. So for practical reason, we should always remember whenever we talk about gray matter, we should think of cell bodies. And whenever we think of white matter, we should think of myelinated axons. So in the spinal cord, where do I find the myelinated axons? In the periphery, right, where I have the descending and ascending tracts. The central gray matter part will mostly have bunch of cell bodies, right? Gray matter is equal to collection of cell bodies, white matter is equal to collection of axons. So if I have to remove the myelin sheath, I have to remove from axons. The cell bodies do not have the myelin sheath. So in the spinal cord, it is mostly going to affect the tracts. We will call them as long tracts because they're either going up from the spinal cord to brain or coming down from the brain to spinal cord. So then obviously comes another question. What is the most common tract that is getting affected in the spinal cord? Most commonly affected tract in the spinal cord. Most commonly affected tract in the spinal cord are going to be sensory tracts. Sensory tracts. So what symptom do I expect if the sensory tracts get demyelinated? I will not be able to conduct the sensory information well from the peripheral body parts to the brain. So what will be the symptom? I will have loss of sensation somewhere in the body. That is the most common symptom. What is the second most common site of demyelination? The second most common site of demyelination is the optic nerve. Optic nerve is the second most common site of demyelination. So if it is causing optic nerve demyelination, the question is whether it is going to affect one eye or both the eyes. Usually it affects single eye, unilateral optic neuritis. So what symptom do I expect when I have unilateral optic neuritis? I will have loss of vision in the one eye. These are the two commonest symptoms that patients with multiple sclerosis they will present to us with. So in terms of frequency of which structure gets affected more commonly by demyelination, we will have a list. The earliest and the most commonly affected structure, as we already know, is the spinal cord. And when we are affecting the spinal cord, among them, the most commonly affected is going to be sensory tracts. Sensory tract. So what symptom I am expecting when the sensory tracts get affected? Loss of sensations. These are the most common symptoms in a patient with multiple sclerosis. After spinal cord, remember, whatever is the case of multiple sclerosis, more than half of them will experience at least one episode of sensory tract demyelination. It is seen in more than 50% of cases of multiple sclerosis. The second most commonly affected site of demyelination in multiple sclerosis is the optic nerve. Optic nerve. So it causes unilateral anterior optic neuritis. Unilateral anterior optic neuritis. So what will be the symptom? There will be unilateral vision loss. The patient may not be able to see in one of the eyes. That is the second most common symptom that we can expect. After that, what other structures can be affected? We can also have the involvement of motor tracts. Again, we are talking about spinal cord itself. What is motor tract? Coming from the brain to the spinal cord, bringing in the information for the contraction of muscles. We can also call it as corticospinal tract, or you can also call it as pyramidal tract. So once I cause demyelination of this area, what symptom I would expect? I will expect the inability to contract the muscles. We will simply call it as weakness, or you can say motor strength loss. That is the other symptom. Okay. What other structures can be affected in terms of frequency? It can also affect the cerebellum. And once cerebellum is affected, what symptoms do I expect? Cerebellar involvement can lead to ataxia, right? Then dysdiadochokinesis. What is dysdiadochokinesis? Remember, diadochokinesis is an ability where we can make rapid alternating movements. For doing rapid alternating movements, I need my cerebellum to work fine. When that is affected, I will not be able to do this rapid alternating movements. That phenomenon is what we call as dysdiadochokinesis. What else I can get when cerebellum is damaged? I can also get action tremors or intention tremors. These are common symptoms we are expecting when we have multiple sclerosis. Obviously, when patient comes to us, he might not have all the symptoms. Whichever structure he is going through the demyelination of, patient will present with those symptoms. Like let us say there is one individual who is going through demyelination of the optic nerve. Then what symptom he is presenting to me with? He will have unilateral vision loss, either right or left eye, he would have lost the vision. I have another patient right now, he is going through demyelination of the cerebellum. So he might have presented to me with ataxia, dysdiadochokinesis, action tremor, and other symptoms, right? But because it is a disorder where multiple episodes of demyelination do happen, if I revisit the history and ask him, did you have any of these other symptoms in the past? Patient may say, sir, yeah, right now I'm not able to see in one eye, but 6 months back or 1 year back, I had lost sensation in one of my arm or one of my leg. So that is pointing towards having gone through another episode of demyelination in the past, right? You follow this patient in the future, somewhere down the line, he may present with weakness of some body part. Somewhere down the line, he may also present with attacks. So remember, these patients will go through multiple episodes of demyelination, and when they present to us, they may be having the objective clinical evidence of demyelination affecting only one structure. Visiting the history is very, very important to unearth having demyelination at the other structures. Okay. Now the question is, can I have ataxia, dysdiadochokinesis, and action tremors if there is a tumor sitting in my cerebellum? Of course, yes, possible. Right. Can I have weakness of some body part if I have a stroke affecting the motor cortex? Yes, possible. Can I have unilateral vision loss if there is retinal detachment or a foreign body or a trauma to the eye? Yes, possible. Can I have loss of sensations if I have diabetic neuropathy? Possible. Then how do I suspect that this is indeed because of multiple sclerosis itself and there is demyelination? Well, what we have understood so far, history is very, very important. A patient is giving history of symptoms involving different anatomical structures, that is your first clue. Then you can start thinking that this time it is demyelination of this structure, in the past it was demyelination of that structure. That takes you towards the diagnosis of multiple sclerosis. But there are also certain ancillary symptoms which can raise the suspicion of multiple sclerosis. Like let us say I got a patient who has unilateral loss of vision, but when I take history, I also get to know that he has this extra symptom which is pointing towards multiple sclerosis. We will call them as ancillary or additional symptoms. What are those? The first symptom that I want you to remember, repeatedly asked MCQ topics, these are the first symptom that we're going to talk about. It will be called as Hermitage sign. I'm writing L here, but please remember L is silent, so we will call it as Hermitage sign. It is typically seen in patients having the demyelination of the spinal cord sensory tract. So if they have gone through the demyelination of spinal cord sensory tract and I suddenly forcefully flex their neck, I will end up stretching that demyelinated sensory tract. I am literally irritating it. And when I irritate it, it will end up discharging all its neurotransmitters and it can send a shock-like sensation down the patient's spine. So what is this Hermitage sign or Hermitage sign? It is the shock-like sensation on sudden forceful flexing of the neck, on sudden forceful neck flexion. This is not specific to multiple sclerosis, but if it is present, it should raise the suspicion of multiple sclerosis and indirectly telling that there is a segment of sensory tract in the spinal cord which is demyelinated and you're stretching it by forceful flexion. Okay. Then the second finding is called as Euthoff's phenomenon. Euthoff's phenomenon. Now, what is this Euthoff's phenomenon? The patients with multiple sclerosis, they can have worsening of their symptoms on exposure to heat. So when symptoms become worse on exposure to heat, we call it as Euthoff's phenomenon. Just to give you an example, let us say I got a patient who is having optic nerve demyelination and because of that he has lost vision in one of the eye. Obviously, when he is losing vision, it is not going to be like zero, right? He may still be able to perceive the light or perceive the movement of fingers or some degree of vision loss. Now let us say this person goes to take a hot water bath. When he takes hot water bath, his body temperature is now elevated temporarily. During that period, the nerve conduction blocks become accentuated or become worse, and the vision loss will become much more severe. So earlier he was able to at least see the movement of fingers. Now he will not be able to see even that. Or at least earlier he was able to perceive light. Now he may not be able to even perceive light. So his blindness got worsened on exposure to heat. It is transient. After some time, once the impact of heat goes away, the vision will be back to where it started. Right? If earlier he was able to perceive the movement of fingers, now he will be able to perceive the movement of fingers. Earlier, if he was able to perceive the light, now he will be able to perceive the light again. But transiently, the symptoms got worsened on exposure to heat. This phenomenon is called as Charan Kumar, I'll come to that. This phenomenon is called as Uthoff's phenomenon. Transient worsening of symptoms on exposure to heat. So I remember a patient of multiple sclerosis who had cerebellar demyelination, and he was doing reasonably well, some mild ataxia, and he was showing some recovery. And then he got an episode of fever. And after that, his ataxia became so worse. Earlier, he had ataxia, he was able to walk with support. But once he got fever, the ataxia was so severe that even managing simple movements became difficult for him. But once we treated fever, he was back to where he started with. So this phenomenon, we are going to call it as Uthoff's phenomenon. Uthoff's phenomenon. Hermitage sign is what? When we suddenly forcefully flex the neck, the demyelinated sensory tract gets stretched and it triggers a shock-like sensation, like you see in this image. The neck is forcefully flexed, triggering a shock-like image. Then the third ancillary symptom that we should be remembering is Pulfrich phenomenon. Pulfrich phenomenon. An ophthalmologist is a better teacher to teach you about Pulfrich phenomenon, but I will try to make it simpler from my side. Let us think about a person who has got demyelination of one of the optic nerve, because multiple sclerosis usually causes unilateral optic nerve demyelination. So let us say my right eye has got optic nerve demyelination. My left eye is fine. So when I'm seeing things happening around me, right, events that are happening in front of me, the eye which is not affected, its conduction velocity is normal. So whenever I see things, it is transferring the information to brain, the occipital cortex, almost in real time. But the eye where there is demyelination, conduction is not totally stopped, but it is very slow. So let us say that I see one person getting up in front of me. First time, the normal eye is conducting it in real time, but the other eye will send the same information of that person getting up, but it will reach the brain little later. So now my brain is seeing two events. It's actually one event, but once it happened, the normal eye conducted it in real time. The other eye conducted the same imagery little later. Now the brain will be literally unable to process this information. How can one single event happen twice? So when brain tries to process it, it starts adding a new dimension. Normally, whatever event that happens in 2 dimensions, now the brain will start thinking that it happened in 3 dimensions. Such phenomenon is called as Pulfrich phenomenon. A classical example is, all we have to do is take a pendulum, hold it in front of the patient who is having the unilateral optic nerve demyelination because of multiple sclerosis, and move the pendulum in 2 directions. So right now this movement is left to right, right to left. It's a 2-dimensional movement. But for this patient, it will look like a 3-dimensional event. So what will it look like? Left and right movement is obviously there, but it also looks like the pendulum is coming towards the observer and then going away. So there is also to and fro as well as left and right movement. This phenomenon is what we call as Pulfrich phenomenon. So in simple words, what is it? 2-dimensional events or imagery appearing as 3-dimensional events as imagery. This is what we call as Pulfrich phenomenon. Why is this happening? Because our eyes, one eye is conducting the same image faster, other eye is conducting slower to the brain. In fact, how these 3D movies are, like how do we watch the 3D movies? You have seen, right? You get the glasses with different colors. Basically, they're trying to trick employ the similar trick so that the 2D things start appearing as 3D to us. Now, is it a safe thing to have? Of course not. You may be thinking like, sir, 2D के theater के ticket में 3D movie का मजा? Of course no. The problem is, especially when you're driving. Let us say that you're driving on a road and then you see a vehicle coming towards you, right? It is supposed to just pass by. वो एक दो डायमेंशन में ही मूव कर रहा है, right? It is away from you, coming towards you. It will go behind you. It's moving in one straight line, right? Like you are driving in this direction. There is another car coming from there, so they will pass through their lane. It's a two-dimensional movement. But for the patient with Pulfrich phenomenon, it will appear like a three-dimensional movement, right? Just like how pendulum was moving in only two directions, but it also added a three dimension, so to and fro. So now for this person, the car will appear to move like this, not in just two dimension. So it can be very confusing to drive in such situation. आप क्या करोगे? If you feel like someone is driving on to your lane, you will drive away from that lane and literally come in the line of the oncoming traffic. It can be responsible for road traffic accidents. अब इसका simple solution ophthalmologist के पास क्या है? Whichever eye is slowly conducting, blindfold it, right? On one eye, the patient will be able to see everything in real time without an unnecessary additional dimension. So in any patient who presented with, let us say, some loss of sensation or loss of vision or motor weakness or cerebellar symptoms, in such individuals, if I see these symptoms, I will suspect that it could be a case of multiple sclerosis. That is an extra point we should always keep in mind. Any question, any patient. If you see Hermitage sign, Uthoff phenomenon or Pulfrich phenomenon, it is talking about multiple sclerosis. Okay. Now we will also address how do we classify multiple sclerosis today, and in tomorrow's class we will talk about the diagnosis and management. So to summarize, what is it? Multiple sclerosis is a demyelinating disorder of the CNS, which is an autoimmune disorder where antibodies as well as cell-mediated immunity is causing demyelination. Demyelination हर बार अलग-अलग जगह को अफेक्ट करता है, इसलिए symptoms भी हर बार अलग-अलग होंगे. Whichever structure is demyelinated, symptoms will be resulting out of that. But if a patient presents with recurrent neurological symptoms, and in them if I find these ancillary symptoms, I am highly suspecting that it could be a case of multiple sclerosis. Now the question is, what is the fate of this demyelination? Will it be permanently demyelinated or will body remyelinate those demyelinated structures? Let us say कि हाँ कोई patient आया था who had demyelination of the sensory tract. Will it get remyelinated and the symptoms resolve, or will it remain demyelinated? Well, the disease is bit unpredictable. In some individuals, after demyelination, there will be remyelination and the symptoms will be gone. Like I had lost vision in one eye because of optic nerve demyelination. Now it is remyelinated, I will get the vision back. In some individuals, the remyelination may not happen at all. In that case, I would have completely lost the vision. In some individuals, the remyelination is partial. And if the remyelination is partial, then recovery is partial. So I had very poor vision. Some degree of remyelination happened. So now my vision is better, but not fully normal. So any outcome is possible. Complete recovery, partial recovery, or no recovery. Okay. So now these multiple sclerosis patients are classified into different types. What is the basis for the classification? It is based on disability progression. Based on disability progression. Now what do I mean by that? I'm a normal individual. I have certain abilities. What are my abilities? I can see, I can smell, I can taste, I can hear, I can move my body parts, I can feel all my sensations, I can maintain my gait, I can walk, I can sit, I can talk. All of these are my abilities. Now let us say these are my 100% abilities. Now I develop demyelination of cerebellum, and because of that I have ataxia. Will I be able to walk now? I may have difficulty to walk. So one of my ability is gone. In other words, I can say I have developed a disability, right? After this, I developed demyelination of the optic nerve. Now I cannot see from one of the eyes. So now I am even more disabled. Earlier, I was not able to walk. Now I cannot walk as well as I cannot see. So my disability has increased. So multiple sclerosis, we will see what happens to the patient's disability over time, because बार बार demyelination होगा, हर बार एक नया demyelination, तो disability शायद बढ़ता जाएगा. So we'll plot the disability on a graph, and based on the disability behavior, we have classified the multiple sclerosis into different types. Now, how do I assess what is the degree of disability? The disability is assessed by, because there has to be scale, right? Like you might have seen that those people who are physically challenged, to be able to qualify for certain quotas, government has specified, right? There should be 85% disability, 70% disability. So they also apply some scale to assess the disability. Similarly, in multiple sclerosis patients, to assess the disability, we follow a scale. So the disability is assessed by a scale known as Kurzges's expanded disability severity scale. Kurzges's expanded disability severity scale. So what we will do is, now let us plot one of the patient's disease course. You will understand it better. On x-axis, let me plot time. Okay, so Chetan Kumar, what Uthoff's phenomenon? Uthoff's phenomenon is, on exposure to heat, the symptoms worsen. Why? Because on exposure to heat, the electrical impulse conduction becomes slowed down. Already there is demyelination, so the conduction is very slow. On exposure to heat, the conduction becomes even more slower. That is why symptoms become worse. Okay. So now coming back to this disability plotting. So we have this graph. On x-axis, I'm plotting the time. On y-axis, let me plot the disability. So on x-axis, I have the time, and on y-axis, I have disability. So basically, we're trying to see how disability progresses over time in a patient with multiple sclerosis. Let us say I got a patient who had first episode of demyelination affecting the optic nerve. Now, this is his baseline ability, which is perfectly normal, fully all right. He has no disability. Okay. Then first episode of optic nerve demyelination happened. Now his disability will increase because now he cannot see. So disability increased. So on the expanded disability severity scale, it will show that his disability is increased because he is not able to see in one of the eyes. After some days, let us say the disability remained like that, but then remyelination occurred and he recovered from the disability. Now he is able to see. But it is multiple sclerosis. So after few days, again, one more episode of demyelination will happen. This time, it may be affecting the cerebellum. And now because of that, he is having ataxia. He is not able to walk. So his disability further increased. But उसके बाद में फिर से remyelination हुआ. So he was disabled for some time, and then remyelination happened. His disability came back to normal. So now he is again fully normally able individual. Let us say after a few days, he had one more episode of demyelination. And this time it was affecting, let us say, motor tract. And because of that, he is hemiplegic. He is not able to move one side of the body. He is now more disabled. But again, lucky chap, he is able to recover from the demyelination. Remyelination hua, and he is able to move body parts now. Okay. Again, let us say after a few days, demyelination affected sensory tracts and he lost sensation for some time and he recovered again. So this can be story of many patients. Now such cases, right, where demyelination happen multiple times, but every time demyelination happens, there is complete recovery. Patient is back to normalcy, leaving behind no disability. Such patients of multiple sclerosis, we will call them as relapsing and remitting type. Such patients will be called as relapsing and remitting type, or we can simply abbreviate it as RRMS. RRMS refers to relapsing and remitting multiple sclerosis. What do you think is the prognosis of this patient? Is it bad or good? Here one demyelination happened, but he recovered completely. Here another demyelination happened, but he recovered completely. Another demyelination happened, but he recovered completely. Another demyelination happened and he recovered completely. So what do you think is the prognosis? So remember guys, why are we calling it as relapsing and remitting? क्योंकि relapse means बार बार disease आते जा रहा है, but remitting because हर बार recover भी हो रहा है. Now, I would not count this as having bad prognosis. Bad for patients because he has to go through those symptoms at least for some time, but he will always recover well, right? I have lost vision in my eye now. After a few weeks, I will be back to full normalcy. So such patients will be considered as having good prognosis. Good prognosis. And thank God, more than 85% of multiple sclerosis cases belong to this relapsing and remitting type. Just to compare, right? I also had few episodes of alopecia areata where I lose some small patches of hair. But every time I've lost, right, I have recovered. The hair comes back. So it is like this variant of alopecia areata that I'm suffering from is having good prognosis. But I've also seen patients with alopecia areata, बाल चले जाते हैं कॉइन शैडोज की तरह और फिर वापस आते ही नहीं है. They are having bad prognosis. So this multiple sclerosis is also like बार बार demyelination तो होगा, but every time demyelination happens, they make a near total recovery, right? Now in the second, the graph is going to look, in the second set of patients, the graph is going to look somewhat like this. Let me show how the second patient's graph is going to look like. Okay, so I have another patient here. In that patient, what happens? Patient had an episode of demyelination, so his disability increased. Now he will not completely recover from it. Disability remains same, but it is not getting remyelinated, no recovery from it. After some days, another episode of demyelination happened, disability increased again, no recovery from it. He remained disabled for few days. Again, another episode of demyelination, no recovery. So his disability is never touching baseline. Every episode of demyelination is leaving him more disabled. Let us say like once I had optic nerve demyelination, I'm not able to see. After that, I had demyelination of cerebellum, I'm not able to walk, I have ataxia. After that, I have demyelination of the motor tract, now I am hemiplegic. So first, I could only not see. Then I could not see, could not walk. Now third, with hemiplegia, I am bedridden. Fourth episode of demyelination, let me say it affected sensory tract. Now I can't see, can't walk, I'm bedridden, neither I can feel sensation. So my disability is increasing right from the first episode of demyelination. Such case of multiple sclerosis, we will call it as relapsing, we will call it as primary progressive. We will call it as primary progressive because no episode has shown good recovery. Primary progressive multiple sclerosis or PPMS. This accounts for around 10% of cases, and we will count it as having poor prognosis because every time demyelination happens, it leaves the patient behind more disabled. So it carries poor prognosis, affects approximately around 10% of multiple sclerosis cases. That is our primary progressive. Why are we calling it as primary progressive? क्योंकि हर बार पहले बार से कभी भी recovery नहीं हुई है, right? Leaving him more and more disabled. After every episode, he is more disabled. In the first scenario, the relapsing and remitting type, demyelination happens again and again. Until that, we will not call it as multiple sclerosis. But every time it happens, patient is making good recovery. So his disability comes back to baseline after every episode. But here, it has never touched the baseline. Disability increase होते ही जा रही, right? So such cases we are going to call it as primary progressive. And then we have a third relatively less common variant where demyelination happens again and again, and their disability graph is going to look somewhat like this. Okay, so let me sketch the graph and then you should tell me what does it look like. What does this graph look like? This graph kind of looks like the combination of relapsing and remitting and primary progressive, right? What does it look like? The initial portion, it looks like the relapsing and remitting type, right? Every time there was a demyelination, disability increased, but recovery hua, that's why disability came back to baseline. So shuru mein it was behaving like relapsing and remitting, but after some time, recovery did not happen, right? He started becoming more and more disabled after every new episode of demyelination. So this kind of looks like primary progressive, this kind of looks like relapsing and remitting type. So such kind of a picture we call it as secondary progressive. मतलब शुरू में it was like relapsing and remitting, but then it started becoming progressive. So we'll call it as secondary progressive. Secondary progressive type of multiple sclerosis. We'll call it as SPMS, secondary progressive multiple sclerosis. It is rare and it affects less than 5% of cases. In terms of prognosis, I will count this as having moderate prognosis. Means it is not as bad as primary progressive, neither as good as relapsing and remitting. Relapsing and remitting का मतलब क्या है? I'm pretty sure that every time demyelination happens, my patient is going to make near total recovery. Primary progressive, I know every time demyelination happens, my patient will be more disabled. Secondary progressive, at least for initial few months to few years, patient prognosis was good. After few years later on, the demyelinating episodes are leaving him disabled. So that's why I'm going to count it as moderate prognosis. Right? So this is how we classify the multiple sclerosis into relapsing and remitting, primary progressive, and secondary progressive. What is the basis for this classification? The disease behavior with respect to the progression of disability. If disability goes on increasing right from the first episode of demyelination, it is primary progressive. Disability बढ़ता है लेकिन फिर से वापस नॉर्मल हो जाता है, then it is relapsing and remitting. Initially relapsing and remitting, बाद में primary progressive kind of behavior, we will call it as secondary progressive. And the scale used for assessing the disability here will be called as Kurzges's expanded disability severity scale. So that's it for today about multiple sclerosis. What we have understood, what is multiple sclerosis? What are the important risk factors? What are the usual structures that get demyelinated? And then how do we classify multiple sclerosis, taking into account how the disability progresses over. In the next class, we will talk about the diagnosis. One important point I will tell you, maybe you can spend some time before coming to the next class. How do we assess the, how do we make a diagnosis of multiple sclerosis using what is called as McDonald's criteria? Remember, the essence of multiple sclerosis is two things. Demyelination, which is recurrent again and again, and every time it's new anatomical structure. So I have to prove that a patient who presented with some neurological symptoms has demyelination, which has happened multiple times, and every time it has affected a new structure. That is the essence of diagnosis. We will see the essence from the spectacles of McDonald's criteria in the next class, and then we will talk about the management, and we will also go through some of the important MCQs from this topic. The notes will be shared on the PW Med Telegram channel. Those who are not familiar or connecting with me for the first time, you can download the notes from that section of the Telegram. See you soon, guys. My phone is off, so I may not be able to take some of your doubts. But whatever pending doubts you have, which I am unable to see right now, I will either follow through in the Telegram or in the next class, I will address them. See you soon, guys.